Hello and welcome to Sensei podcast. This is Manos Brilakis discussing with leaders in the field of CTO and complex PCI. Sensei means teacher or master in Japanese. The goal of the Sensei podcast is to help you learn and improve in CTO and complex PCI so that you can become the best that you can be and offer your patients the best possible results. Hello, everyone, and welcome to Sensei Podcast. It is my great pleasure to introduce our guest today, Dr. Evald Christiansen from Aarhus University in Denmark, one of the leaders in CTO and complex PCI, both in the clinical world, but also in the research world, with several excellent studies that have shaped the way that we approach CTO PCI right now. So, Evald, thank you so much for joining us today.
Thank you for having me.
And maybe, Evald, can you give us a little outline of how did you end up getting into this area of CTO and complex interventions? Was that something that you always wanted to do? Was that something that came up later during your life? How did this happen?
Well, it came out in the end of my training period when I learned to do PCI. Sometimes we got patients on the table with a clinical problem, and then I saw some of the arteries were completely closed. And I thought that we should try to treat these patients also. And I had a senior colleague that was very interested. His name was Leif Tusen, and we started together to do interventions. We started in the period where the Euro CTO Club started. In 2006, my senior colleague visited a meeting in Frankfurt, and he saw Japanese operators coming in. So we invited Sushikane to come to our center, 2007, and he taught us to do retrograde procedures. So that was how it started.
Wonderful. So the clinical need, and you got some help and some proctoring from Japanese operators who obviously pioneered the procedure and took it to the next level. And then how did you take it into the day-to-day? Because from the proctoring to the real day-to-day life, there's obviously some distance. But how difficult was it? Was the hospital and the colleagues and the administration supportive for building up the program?
I think we had a great support in the beginning, and the volume was not that high. So we could see that the patient came to our cath lab with a problem. We tried to solve it, and of course there was some expenses, but it was accepted. And also the thing that we learned when we did CTO PCI was something we could use in other cases. So if there was problem in other cases, you could take on board the CTO techniques. If you were in a STEMI patient, you were not sure if you wired the artery, you can do a retrograde injection in selected cases. So the colleagues accepted it. And there was not much interest from the other colleagues to do this intervention. So there was not much competition to take them. So it was possible to get a certain amount of volume. And then I also realized that the more I did, the more I had success. So therefore, very early, I tried to get in connection with other centers to come and do cases with them, to increase my volume. And we realized that very early that volume mattered.
So you had other people bring their cases over and collaborate. How? Because I know many people right now in the US are also doing the same thing. They try their cases first. If it doesn't work, then they bring the patients to another hospital with a more experienced operator and do the case together.
Yeah, that's a collaboration we have. And it's something that also evolves in the way that they see that the patient have their case done. They have the successful procedure. So they see that in the outpatient clinic that it's helpful. And that brings me also to this interesting discussion about, can we take patients into trials and can we just do them? Because if we try to randomize to get the evidence, we will only get patients that accept the randomization to medical therapy and also the doctors. So we have the risk that there is a bias towards randomizing low symptomatic patients, and the real symptomatic patients are requesting the treatment. So it's a difficult scenario, and I wonder if we will ever get data for showing that this is really beneficial, because it's clinical experience.
Yeah, no, absolutely. And I think we'll get into that. I know you have many research studies running right now, and that's obviously has been one of the key issues with randomizing those patients, who, as you said, the most symptomatic ones don't want to enroll. Having said that, doing the cases and the complexity, the time, the effort, and the complications are a big part of that. So, how do you manage the psychological aspect? Do you get nervous? Do you get anxious during those cases?
No, I don't think I get anxious. I try to prepare and think of all the stuff that can go wrong, to prepare for complication and change the strategy if I feel that this is going in the wrong direction. So if I'm anxious, I think I'd rather stop doing a procedure, because if you're anxious, that means you are out of control. And it's also nice to have good colleagues around, that you know that if you have a pericardial effusion, you know that there is a colleague that can come in and do a pericardiocentesis. So we have a very nice setup that everyone is set up for handling complications in that way. If you go to another center and do procedures and you don't have that backup, that you have to do it yourself and they don't have the coils yourself, that can make you a little anxious. But I think you should try to prepare that everything you need should be in the cath lab. So I'm not nervous for procedure.
And that's, as you said, that's important, because I guess if you get very nervous, then the performance probably goes down, since you are not as focused and not as adept at handling the issues and preventing or treating complications. But even, with in the best hands, things can go the wrong way. Procedures can fail, or sometimes complications can happen. How do those affect you? Do they bother you much? Have you got used them over time to overcome them? How do you handle complications and procedural failures?
I think talking the cases over and over again with colleagues and the nurses in the room, and we debrief all the time. If there is something going wrong, we discuss how did we handle this situation. And every time you talk a story through, you feel better about it. And we also have the tradition, we bring it to the big morning conference. And every time we have a big complication, we tell them what went wrong. It's like going to the church and you sit next to the priest, and we joke a little about that. We say that we sit and tell everything, and it helps you talk it through.
Yeah, and obviously communication does help enormously with that. And as you said, having supportive colleagues that can do this in a constructive way rather than a critical way is also very important. And then, in terms of the planning and the preparation for the cases, is there something you do different now than you were doing, let's say, 5 or 10 years ago? Or you've got a routine that you use in most or all of your cases?
I think we changed a little towards be very sure of the indication. Have the patient tried medical treatment? Are the patient aware of the success rate and the risk? And is the ratio between the success rate and the risk beneficial for starting the procedure? And also be able to adapt to that during the procedure. So we really go very carefully through the information level for the patient, the indication for doing it. Do we have all the equipment there? What is your plan A, B, C, and D? So we are absolutely sure of everything.
Wonderful. And again, obviously, these are complex cases and careful planning is critical. But again, I need to congratulate you, because you've taken this one step further. And although most people have given up on the quest of making a big trial on CTO PCI. I mean, you have ischemia CTO running, one of the studies hopefully can answer many of the unanswered questions in the field. So tell us, how did this come along, and how do you decide to embark on this journey, and how this journey is coming along?
I think it came from the discussion in our department and with colleagues that what is happening to the level of evidence in the guidelines? Can we continue to do this without having the evidence? And I can easily convince CTO operators that it's a good procedure, but can I also convince non-invasive cardiologists? Are you just doing this for fun? Some there's discussion there. Are you just following the push from the industry that the devices are very expensive? So there is an industry push, but I think we should try to push that back and really focus on the patient need. What is it beneficial for the patient? Of course, when you start PCI, it's also a good idea to have a certain amount of volume in complex cases. And you learn a lot, but always have the patient in focus and always strive towards generating the evidence. We have a policy in my department that the result of the treatment we give today is the result of research and randomized trials. So we always try to randomize a patient to generate knowledge that will benefit future patients. So I think we should do...
Yeah, absolutely. No, I'm sorry, go ahead.
So I think that we should try to go for generating the evidence if it's possible. But also, what is the evidence? Do it always get the evidence from randomized trial, or how do we get the evidence from registries? So it's also important to track the patient that were screened for a trial and see how it goes. So we are trying to also have control of the screen population and see if they do well after the treatment compared to the randomized patient, and what is the characteristics compared to the randomized. So tracking the results of your treatment in registries is mandatory, I think, when you have a procedure that has a certain risk. So we have to know what happens to these patients after we send them home.
Wonderful. And you're right. As you said, many of them, the most symptomatic ones likely are the ones who are less likely to enroll in the studies. But still, the scope of the study is big, right? The number of patients is huge. And finding those patients, I know Denmark has a very nice network of hospitals working together. But how were you able, again, to get this launched and get it off the ground? And how, if you maybe tell for the people who are listening, who are not familiar with it, maybe a brief overview of how the study is going, and what is the ultimate primary endpoint and primary goal?
Yeah. So why are we opening a CTO? I think that we thought that there could be two reasons, for symptom and for prognosis. So we tried to build that into our trial and say, today we have to accept that the first treatment is medical treatment, because otherwise you don't know if you can have the patient low symptomatic or asymptomatic on treatment. So we will have two groups after 3 months of medical treatment. The patients that are still symptomatic, we can randomize them to open the artery for getting improvement in symptoms. The low symptomatic arm, we will randomize for possible prognosis. So there we require more ischemia. We require more than 10%. And we have a composite endpoint of all we want to avoid by opening the CTO. Mortality, heart failure, cardiac arrest, the need for new interventions. And in the symptomatic arm, we use the quality of life score and see if that will improve in the artery, in the patients that get the artery opens. And after 6 months, we allow crossover. So we can tell the patient, if they want to go into the trial, we will open your artery anyway. It's just a question of is it now or is it in 6 months? Trying to get as high as possible a proportion of symptomatic. A symptomatic arm, we only need 360 patients to have power enough to show superiority. And we lack now 100 patients. So we have 260, and we are waiting for the last 100. I think we can get them in 1 or 1.5 years. And then we have to wait 6 months for the endpoint. The prognostic arm is more difficult because some centers are reluctant to randomize a patient to a procedure if they do not have symptoms. So after some years, we will have to discuss if we have to cut down the number of patients, as EuroCTO trial had to do, the Decision CTO had to do. All those trials had to stop at a certain point. On the other hand, due to a long enrollment period, we accept that the follow-up period can be 7 or 8 years in the first included patient. So we'll see in some years if we have to cut the number of patients in that arm.
Wonderful. And again, it's great to have the multifaceted approach. And actually, even in the symptomatic patients, I suspect that many of them will have actually more significant ischemia too. So they could also potentially have benefit in terms of the MACE. But the problem, of course, is if they're crossover in 6 months, then you probably have less of a time to observe that difference. But again, I think it's a beautiful design. And I know we'll be debating about actually both questions, but especially the MACE and the hard endpoint reduction remains elusive, and it's hard to see, with ischemia and other studies, remains to be seen. Now, there has been, as you know, many attempts to do a study on SAM CTO. Now, ischemia CTO does not have a SAM control, if I'm not mistaken. What are your thoughts about that part? Do we really need it? Do you believe that if ischemia CTO, the symptomatic arm, is positive, that's the definitive answer?
I think that's a very important question because one of the endpoints, the quality of life endpoint, is also questioned. The patient are questioned, are you afraid of having a heart attack? So if you open an artery, you show a patient a picture and say, you're good, you're safe now. They are not scared of having a heart attack in the same way. So it can be more difficult to show quality of life improvement in a sham study. On the other hand, if the patient is really feeling a better quality of life, does it matter? So you have a patient on the table, you are connected to the patient, you open the artery, and they feel safe with that. So that's really difficult to say that should we have another endpoint than quality of life? Should we do an exercise test to see if they have longer exercise time? And so, but the endpoint is very difficult, and it will also be difficult to do a sham trial. I think you tried to do one at a certain time to put a patient on the table, let them lie with a radial sheath and a femoral sheath in 2 hours, listening to music on the headset, and then tell them, I cannot tell you what we did, but we'll see you in 6 months and we'll see what is your quality of life. I think the selection there of patients will be even higher, because who want to spend 2 hours on the table without knowing if they have a potential benefit? So that trial will be very difficult to do, in my opinion.
Yeah, no, absolutely. And it has been difficult, and I guess time will tell. Time will tell if this happens. But again, I'm very impressed because there are very few people in the CTO world that can bridge the gap between the clinical practice and the research and trying to merge those together. And you've been on the forefront of this. And again, congratulations on running the study, and we're very excited to see the result once they become available.
Thank you.
Now, coming to the teaching part, you're a part of the university. How difficult do you find teaching CTO and complex PCI to the new generation of fellows and young operators?
It is difficult to accept that you have to give the volume of CTO procedures to one fellow in the cath lab, because there's not volume enough to let everyone do CTO PCI. So one way to do that is say that this is not CTO, but this is more complex PCI, and say that all fellows trained in PCI should have at least 6 months together with a chip operator, CTO operator, to learn how to handle severely calcified arteries with reduced ejection fraction. So CTO is just one little part of complex PCI. So I think every operator should handle complex PCI. You meet them in the middle of the night when you're on call. So you need to have some level of experience, but going retrograde should not be for every complex operator, because it matters with the volume. How do you get a wire through a collateral? It's not something you just do 4 times a year. So therefore, CTO should be a dedicated procedure for some operators. It is. It depends on also where you are in the phase. If you are just a new educated CTO operator and you want to give volume out, but what we learned now is that always be 2 operators together, because then the amount of CTO procedures will give experience to 2 operators. So we think the number of CTO is going down a little, also because we randomize half of them to medical treatment. So we try to share procedures and switch. That's also, if you are feeling operator fatigue, and if there's 5 difficult points in the procedure and you have solved 3 of them, maybe the other operator can do another bending in just another angle and fix this and then switch back again. So the switching in a procedure is also a way to share experience.
Wonderful. But then, as you said, if there are multiple people who are interested, what makes you choose one fellow versus another? Is it the enthusiasm? Is it their skills, their manual skills? What makes you decide which person may be the best to teach and become good at these advanced techniques?
I think it's a question. So can I have the question again?
Yeah. So how do you choose? As you said, you don't have enough cases to teach every fellow how to do complex PCI and CTO PCI.
Oh yeah, how you identify.
But
yeah, I think it's a question of the fellow is feeling comfortable. So if you see that the fellow is feeling comfortable in a procedure, in a long procedure, or you have the feeling that the fellow rather want to have a quick procedure, so it's kind of selecting itself. If you do a complex case and the fellow comes into the room and are very interested, it's helpful. So to identify the one that are really interested.
Absolutely. Now, you have obviously a very busy schedule with your clinical work and your research work. How do you keep yourself in good shape? Do you do any exercises, any meditation? How do you keep you engaged and feeling good enough to tackle all these tasks?
Yeah, I'm so fortunate that I can go by bike to my work. So I have 1 hour on a bike every day. That's the exercise I get. And try to be healthy and try to get a good night's sleep when you're not on call. Try to eat healthy stuff, and that's how I try to.
How many hours do you sleep every night?
Oh, I sleep 6 to 7 hours.
Okay. And then, do you go in on your bike if there's a STEMI as well? If there's an ST elevation MI, or that's
No, that's not possible.
That's too hard,
I go by car then.
Okay.
Yeah.
Okay. And then, do you have a favorite book or a favorite movie?
A favorite movie, that's an old one. That's the Da Vinci Mystery. The Da Vinci Code. The Da Vinci Code. I like that one. Books. Yeah, that's the book. Maybe that both the book and I also like the CTO manual and the PCI manual. Yeah, that's very useful.
This can be a boring reading, I guess, but but in terms of your day-to-day operations, so how much time do you spend in the clinical realm, in the cath lab versus research and other things? Do you try to merge them the same day so you have separate days? How do you make it all merge into one?
I think I have around 3 days in the cath lab in a week, and then the rest is for research and on call. When we are on call, we can take care of the calls from outside and do some research and office work, clinical checkup, and so 60% in the cath lab and 40 office work.
Wonderful. And now, how do you see, you've been obviously in the CTO field for many, many years. How do you see the field going forward? What are the things that you are excited about that they think they may bring us to the next level of the procedure?
I think there are improvement in the equipment. I think there are equipment on the way that can make the procedures more safe and fast. So I think we are moving ahead towards better success rate and lower complication rate. Procedural planning, CT scanning before procedures, re-entry devices, and maybe also we saw these devices from Japan, these plasma wires that when you want to make a connection between two wires, you can do it in a quick and safe way if they come to market.
Wonderful. Yeah, so I guess new devices, which again, we don't, I think since the Stingray for back in many years ago now, more than 10 years, I don't think we've seen any major device come into play, but you're right, there are more devices coming up. There's a new re-entry device, there's the plasma wire, so more things coming down the line. But there is that feeling that maybe we're a little stagnating and there's room for improvement there as well. And of course, what you're doing, the research is important to find, the solid evidence behind the procedure. In terms of learning and teaching the procedure, are there any things that you found useful for yourself to learn or teach for others as well?
I think the review of the angiogram before you get into a procedure is very important. Trying to understand the anatomy in every detail, and then also let the operator, the learner feel the wire and come with a suggestion themselves, and if it doesn't work, change the strategy. So this is also for PCI outside the CTO. If it doesn't work, take a new projection or new wire or new bend, because it's very rare that you get a lucky punch by doing the same movement in the same projection over and over again. And I think you often identify the good operators in the way that you find an operator that has both hands and ears. So you need to be able to listen, and you also need to be able to use your hands. That's the one that learn the fastest.
Absolutely. So, Evald, what are you most proud of from the many things you've achieved, so many studies, publications, clinical work? What are you the most proud of so far?
I think the team effort we have in our research group, that we are able to come with an idea. The last trial we did was the October trial, the OCT guidance in bifurcations. Having the idea, writing the protocol, getting the funding, getting the centers to work together, getting PhD students on board, and finalize the trial, showing a superiority of imaging versus not imaging. I'm very proud of that one. It's not, but I'm proud of the team and not proud of myself.
Well, the team needs a good leader.
Mm.
So clearly, it's a team effort, but it takes a strong leader to be able to pull this all together. And obviously, that was a major trial and came at the right time too, as well, with Illumian and the controversy that came up on this field. So, yeah, I mean, congratulations again on running the study, a successful study like this. What are your personal plans for the future? What excites you for the future?
I would like to run another big trial, and I'll try to get the funding for that. So I think we need another big trial after the imaging trial. Some imaging trials showed that we did not have the benefit for the hard endpoints of imaging, and some others did. So I think we need more evidence there. And the reason I think we could do it is also that even though some feel there is evidence for using imaging, operators don't do it. So that gives us the room to randomize, to force some of the non-believers to do it. And when they do imaging in the cases where they thought they saw everything, they can also become believers. So if we have learning built in to randomization, then we have the benefit for the patient, for the operator, and for the modality. So that gives a benefit for all. That I think we should do. And then what I will also try to teach my colleagues to do CTOs, the ones that want to learn it.
Wonderful. Well, again, Evald, it's been amazing talking to you, and congratulations for getting so many things done, both on the clinical work and on the research work. If you had to give some parting thoughts about the people who are early in their careers and they're considering a career in CTO or complex PCI, clinical and or research one, what would you advise them to do so that they could become successful?
I think they should, of course, connect to the local team if they have a program in the department to say, I want to be on board in the CTO team. If you're in a department that don't have a CTO program, they should have the support for a program and then maybe travel to a center for 6 or 12 months to get the volume. Travel to a high volume center to learn the technique. And when you come back and you want to set it up, get some proctors to come and help you. So volume and proctoring and the support in your department, that's important.
Wonderful. Well, once again, Evald, thank you so much. It's been delightful talking to you today. And congratulations on your new study. We're very excited to see the results of ischemia CTO. I know it may take a few more years, but we're looking forward to it. And looking forward to working with you as well. Thank you so much.
Thank you for having me.
Thank you for listening to the Sensei podcast.